Good afternoon, and happy Sarcoidosis Awareness Month. I am Diane Driscoll, Global Head of Clinical Engagement. Welcome to the second FSR Sarcoidosis Journal Club. This is a live meeting format, and you are invited to keep your cameras on throughout. Use the chat during the presentation to ask questions, and then raise your hand during the open discussion. Please have your mics on mute until then. We will be sending up a follow-up survey that needs to be completed for the CME credit. As always, your feedback is critical for future programming, so please take a moment to answer the short survey. This session is being recorded and will be available to all Alliance members. Here is what you can expect to see today and who you will hear from. Before we get started, a reminder of the learning objectives and disclosure statements from all involved. This signature programming is brought to you because of the FSR Global Sarcoidosis Clinic Alliance. These 38 clinics have joined to be a part of change, combining expertise and knowledge for research, education, patient support, and to advocate for sarcoidosis worldwide. 2023 membership is open to USA clinics, and founding membership is available for international institutions. Meet our leadership committee, comprised of Alliance founding members. Thank you for your time, your proficiency, and your counsel in building this signature educational program. Thank you to the University of Florida Medical College at Jacksonville for access to their CME platform. All Alliance programs in 2023 include leadership committees, and many will include CME for live attendees. Today's featured publication was selected from a list of literature curated by our leadership committee. I would also like to thank Boehringer and Ingelheim and Mallinckrodt Pharmaceuticals for supporting FSR's educational mission. While keeping the patient at the center of everything we do, our vision at FSR is to provide the framework to support all stakeholders and all institutions in this disease. We believe in the power of many to join forces for true game-changing results in sarcoidosis. By supporting patients, clinicians, researchers, and lobbying for policy changes, we will get closer to these goals. I am proud to announce the FSR inaugural Sarcoidosis Crystal Awards Gala, bringing together the community for an evening celebrating clinicians, researchers, and advocates from around the globe. We hope that you will be able to join us for this event. FSR offers many options for clinician education and engagement, and each program approaches patient care and clinic learnings in a unique format. Please join us on April 26th for our inaugural peer case review session. This is the second club of a 6-part series answering your call to action to create a journal club dedicated to sarcoidosis. We asked, we heard, and we are delivering. We are here to empower and inspire you, to engage and encourage learning from each other. Journal clubs lay the foundation for critical thinking skills. I suggest we are here to lay the foundation for critical rethinking skills. We want to knock down silos and connect you with peers to gain knowledge from recent research findings and to consider and to reconsider the methodology with suggestions of how to make it even better. Together, we will raise the bar. Thank you to our co-hosts for this club, Cedars-Sinai Medical Center in Los Angeles, California. Dr. Bobak Ockhaven is a native of Los Angeles and has traveled to Granada, Brooklyn, and Houston to complete his postgraduate medical training. He completed an additional chief residency year at the University of Texas McGovern Medical School, and he was a chief clinical fellow at Cedars-Sinai. Dr. Ockhaven is currently the medical director of the Pulmonary Sarcoidosis Program and is working with the multidisciplinary team to expand their center for sarcoidosis. When not at work, he is busy running around with his energetic 2-year-old son and his dog. Dr. Ockhaven's discussant today is Dr. Elizabeth Frame. Dr. Frame attended medical school at Columbia University's College of Physicians and Surgeons. In 2018, she moved to Cedars-Sinai, where she sees a wide range of rheumatologic diseases and teaches medical students, residents, and fellows. She and Dr. Ockhaven, together with Dr. Evan Kransdorf in cardiology, have organized a group of physicians from multiple specialties with an interest in sarcoid, and they are working to improve multidisciplinary care for these complex patients. And with that, Dr. Ockhaven, welcome, and please share your screen.
Hey, Diane, thank you so much. Excited to be here and discuss this with everybody from all over. Let me share. Confirming you can see my screen in non-presenter mode and hear me?
Confirming, and we can hear you.
Okay, awesome. So we'll get into it. We're going to discuss this article here published about a year ago in Respiratory Research, infliximab therapy in refractory sarcoid, a multi-center real-world analysis. I have no disclosures. We're going to go through a little bit of background, just kind of leading up to it. We're going to review the methods, the results section, everything in the paper, some of the discussion points that the authors brought up, some strengths and weaknesses, and then afterwards we're going to go through inputs and comments, and hopefully everybody kind of gets involved and we kind of have a good debate, discussion, and bring up different points and hear different people's opinions. I'm going to kind of go through the beginning part of my talk a little fast. I just want to kind of have some slides for reference just to kind of make a couple points leading up to the article, and then the heat of the discussion will be reviewing the article. So just some basic points. We obviously already know that TNF is very much involved in granuloma formation through various mechanisms of action, and also in multiple diseases with granulomas, not just sarcoid. But we also know that in sarcoid, if you look at alveolar macrophages in sarcoid, they seem to secrete more TNF than when compared to healthy controls. 1 second here. Okay. We know that mostly in IBD research that TNF blockade does many things that are helpful for anti-inflammatory effects, cause apoptosis in inflammatory cells. Even infliximab and adalimumab have been shown to lyse TNF-producing cells in vitro, and we have several TNF inhibitors here. Infliximab was the first that was FDA approved in 1998 for Crohn's disease. So this here illustrates, this is actually data taken from a randomized clinical trial that I'll show you in a later slide of infliximab in sarcoid patients. And they took the serum of 134 patients from that trial over here, and they measured the TNF levels in the sarcoid patients and compared them to 50 healthy controls. And as you can see, the baseline TNF levels were higher. And these are patients on chronic steroids. Every patient that had to be enrolled in that trial had to be on chronic steroids for 3 months, and they still have TNF levels that are high. Over here on the right, they actually looked at like 90-something proteins and their expressions, but just focusing on TNF, they look at the samples again after 24 weeks of treatment with TNF. Again, these are samples taken from that randomized trial, and they found that here's a placebo 3 milligram per kilogram and 5 milligram per kilogram dose, that the TNF level reduction correlated with the TNF inhibitor use. And then up here, this is a plot with FVC, and this is a plot with 6-minute walk test. And also what correlated is that as they were using 3 milligram and 5 milligram per kg in the black, there's a correlation with the infliximab or TNF inhibition and improved FVC and improved 6-minute walk. We know that TNF has been used in lots of inflammatory diseases. There's tons of randomized trials in inflammatory bowel disease. There's all kinds of data that support its use in that. But then in sarcoid, we're kind of limited in our randomized trials. There's actually a lot of non-randomized data for sarcoid, but in terms of randomized trials, we're a little bit lacking here. So this is one trial that we kind of always talk about. It's sarcoid. It's got to come up. It's sort of relevant in our paper that we're going to be talking about. So it's not a journal club about this paper, but just very briefly, this was a trial in 2006, published in the Journal of Respiratory Critical Care Medicine. It was a phase 2 trial, 138 patients. All of them had biopsy-proven sarcoid. They were all on at least 10 milligrams of prednisone. They were all stable patients. They were not like they were deteriorating. They're all stable patients. And they basically looked at infliximab versus placebo in 2 different doses. And their primary outcome was what was their FVC at 24 weeks. So over here on the right, you can see this is the combined all infliximab doses, and there was a 2.5% improvement in FVC. Unfortunately, no improvements in the secondary endpoints. Obviously, there could be discussion about if that's meaningful or not, but this is showing that at least these patients that were on chronic steroids for a while, they still had some improvement with infliximab. And then in some post hoc analysis data, actually patients with more severe disease, and some patients with higher CRP, for example, and things like that, there was actually an even more pronounced response. So moving forward, a couple more areas where TNF has been looked at, again, retrospectively. This is a retrospective review of 6 US centers in CNS sarcoid. Majority of them actually had biopsy proven in the CNS of sarcoid, and they were diagnosed or on therapy for at least 1 to 2 years, and they looked at MRI response, and they actually found 82% of them had a favorable MRI response. And actually also a lot of the patients were able to come off steroids. Again, this is a retrospective review, but a lot of the patients were able to come off steroids in this. And another big thing that they find, which sort of relevant to our paper that's going to come up, is that there was a lot of recurrence when there was discontinuation of infliximab. These are 2 trials in uveitis. There's one in Lancet, one in New England, 2016. They're actually kind of similar. They used adalimumab, similar doses. They both looked at time to treatment failure, and they both had a clinical and statistical significant outcome with adalimumab. In these trials, there was 32 patients in the Lancet trial and 18 patients in the New England trial with sarcoid. So I think we can kind of extrapolate some relevance there. Last area I'll mention is cutaneous sarcoid. So this is a retrospective review of a database at MUSC where they looked at facial photographs basically to grade if there was improvement or not. And they looked at all kinds of therapies. So there's steroid-sparing agents, steroids, combination, and infliximab. And there was 54 patients, and actually in this group, a lot of them were African-American patients. A lot of them had extracutaneous disease, and a lot of them, there was several years before they got on therapy. And there was a dramatic difference. I mean, almost 80% improvement in infliximab as compared to the other medications. And we know that lupus pernio is a difficult to treat disease. And so this is kind of a, even though retrospective, arguably an important finding. So leading up to our paper, the authors they state that basically they're investigating the long-term effectiveness of infliximab and an international multi-center respective cohort of patients with refractory sarcoid. They looked at basically anybody who had a pharmacy prescription for infliximab for sarcoid, and they looked at that over a 10-year period. There was 3 tertiary centers, 2 of them in the UK, 1 in Canada, that were looked at. Basically retrospectively looking at all the clinical data, reasons for treatment, doses, durations, and stuff like that. They did state that I guess the 3 centers potentially, when they determined someone was needing to be on infliximab, it was done so by a multidisciplinary discussion with pulmonary, dermatology, ENT, rheum, and neurology, and that's how they kind of made the decision to start infliximab in these patients. They excluded patients with latent TB. They characterized patients by their primary target organ that it was initiated for and how many organs were involved. And they basically looked at treatment success. So obviously we've talked about 2 areas that are a little ambiguous in sarcoid, what's refractory sarcoid and what's treatment success. In their group, this is what they defined. So in the lung, they said that they used spirometry, looking for an FVC or FEV1 improvement by 10% or no change. In the skin, they looked at images, clinical images. Upper airways, they looked at improvement in CT or endoscopy exam. CNS, they looked at MRI, and I'm just trying to point out here that for the lung and the CNS, they are accepting no progression as a success, as opposed to all other organs where some improvement is a success. So in this case, if there was no change in FVC or no change in an MRI from baseline, that's considered a success. And then a couple of these arbitrary areas, GI, normalization of lab testing, resolution of symptoms. So just to kind of recap, they looked at improvement in skin and airway lesions, resolution of lymph node, GI, or joint, resolution clinically or laboratory, and then improvement or no change at all in CNS or pulmonary manifestations. So obviously this was retrospective, so there was differences in how they dosed infliximab a bit, but mostly it was 3 to 5 milligrams per kg, which is similar to that randomized trial. And the one thing is that it was based to the physician how they followed up testing and all kinds of stuff like that, duration. So there was some differences there. So I'll take a pause here. This is kind of like one of the big tables to focus on in the results. This is the baseline characteristics. So I'm going to kind of try to break it down a little bit so we can focus on different areas. So 33 patients in this group, all of them had biopsy-proven sarcoid. Of those patients, not surprisingly, majority of them were Caucasian, but there was 33% of patients in this group were African-American, which is helpful, obviously, when we're looking at refractory sarcoid or difficult to treat sarcoid. In their PFT findings, their baseline average FVC was 84%. They have quite a huge range here, which is a little bit difficult to make of it. I mean, one end 44% of patients and on one end 144%. So quite a huge range. In that randomized trial that I had mentioned earlier, the FVC baseline in those patients was about 70%. The DLCO 57% in these patients. And then all of the patients actually were on steroids prior to receiving infliximab, and all of them had received at least one second-line immunomodulator therapy. So obviously, when we're talking about retrospective, we don't know, how sick were these people, what was their course going in, but it does say something that they were all on steroids and they all did receive a second-line therapy. In the group, most of that second-line therapy was methotrexate. There was actually quite a bit of hydroxychloroquine in this group, and as you'll see in the later slides, there was also quite a bit of skin manifestation. So I'm not sure, and there might be institutional variation why they picked that or not. I'm not sure. Also, it kind of makes you think that there's some potentially TNF inhibition with hydroxychloroquine. Maybe that helped or didn't help, or who knows. And then the other part that was, I don't know what to exactly make of it. They used, there was 10 patients, actually quite a bit, who had IV methylprednisolone. In some of the fine print, they stated that some of the infliximab infusions were given inpatient. So I'm not sure if these were admitted patients or what. This is kind of like up to question. The other thing that's not here is what was the total dosages and duration of steroids. Like, for example, was someone on steroids for 3 months or 2 years? That's not really here. This is just for comparison to the infliximab randomized trial from 2006, kind of looking at the two groups just to see how they compare. They actually also had 27% African American, so not too different. The FVC we talked about a little bit different. Baseline was better in this group than it was in the trial, although there was a huge variation in this. And then prednisone dose actually in this trial was about 12 milligrams on average, as opposed to our patients, which I'll show you in a later slide, was about 20 milligrams. So you could argue that these patients were on higher dose of prednisone than that trial. So maybe they were sicker. It's hard to know. Okay, next table that's quite important that we'll kind of go over step by step. This is basically their results stratified by organ involvement. So majority of patients, as expected, had lung involvement. The second most common was skin involvement. And out of those, actually quite a bit of them had lupus pernio as their skin manifestation. There was 9 upper airway, which is a decent amount. I'm not sure if their institution maybe evaluates that more. Eye involvement, there was a decent amount. CNS, there was a decent amount, which I think is helpful when we're talking about infliximab based on the prior retrospective studies that I showed you guys. Another important thing is that there was really only 3 cardiac patients in this group, and then only a few in these other organs. Out of this whole group, majority of them, 64%, had 2 organ involvement. So a lot of these patients were multi-organ involvement patients. So moving down over here, this is basically when they looked back and they looked at what the reason was that infliximab was prescribed. That's written here. So 33% of the patients had infliximab prescribed for their lung. But that being said, 30 patients had lung involvement. So only 14 of those patients actually needed infliximab for their lung. A large amount of them needed it for their skin. So those are the 2 most common reasons. And then there was 6 who needed it for CNS, and really only 1 in this group for uveitis. And then I guess I should have mentioned this earlier, but 60% of the patients were on, during the time they got infliximab, were on a steroid and in a second immunosuppressive agent. And actually a third of patients had an additional immunosuppressive agent added while they were on infliximab. I guess we're going to assume that maybe is to prevent HACA, but it's not entirely clear, but that was added on, and obviously their institutional policy would help understand that a little bit better. Some more results. This is a picture that they had actually of a patient with plaques, papules, and pigmentation from cutaneous sarcoid, and this is pre and post infliximab, and you can see that there's a pretty significant difference or improvement there. So they're saying actually that out of their 12 patients with skin involvement, 92% of them had a improvement. And remember that 8 of those were lupus pernio, so a pretty big amount had an improvement. 79% they're saying had lung success, and remember success could be no change. So we don't know if someone had no change for a year going into this, and then they were on infliximab and they still had no change, and they're counting that as success. It's hard to know. And also the other part about this is that there's 14 patients here and with lung involvement, but only 11 had spirometry. So that's something that we can discuss later. Out of the 6 patients though with CNS improvement, 100% had success, which again is either an improvement in MRI or no change in MRI as the definition of success. So moving forward, this is the patients. On the top is the FVC, on the bottom is the FEV1. It's looking at their baseline and then 12 months later. And then there was 5 patients who actually had data that went on to receive 36 months of infliximab, and here's their data there. So looking at the top at the FVC, neither of these has statistical differences, but there was a drop in about 20 cc's from baseline to 12 months at FVC, which on average was continued out for 36 months. Again, we don't know the trajectory. I mean, if someone was declining, and then stable, that's one thing. If someone was stable the whole time and improved, that's another thing. I would say here that, when they're looking at the average, there was no difference, but there's only 5 patients here really. But if you see, there's a couple patients that really had a decline here, and then there's a couple patients that had a pretty big improvement. So if that was a bigger sample size, it would be interesting to see how that would make out. The FEV1 was kind of interesting. There was actually an improvement in about 90 cc's from baseline to 12 months after being on infliximab. And that wasn't statistically significant. If you kind of look at their baseline, their FEV1 baseline was about 74%. So if you were to guess that that's about 1.6 or 7 liters or something like that, 90 cc's is actually about 5% improvement from baseline. So you might argue that that is a kind of an improvement. And then remember, there was about I think 9 or 12 patients with upper airway involvement. I don't know if that had airway involvement in their airways, and maybe that's why the FEV1 improved. But either way, this is continues to be for 36 months. And again, this is even a stable patient for 36 months. You might argue that that's an improvement. I mean that's a success as well, if you're talking about a patient who's on multiple therapies and maybe declining before that. This, I think, is pretty meaningful in the sense of a retrospective study. 22 of the patients had data about their prednisone dose before and after the infliximab. And on average, remember we said about the average dose was 20 milligrams of prednisone. At the end of the last recorded day that they followed up the patients, the average dose was 10 milligrams. So that's about a half reduction. And so you might argue that alone is a meaningful success. Few more endpoints to look at. So they had data for 11 patients that discontinued therapy, and out of those 11 patients, 7 of them relapsed within the year. We don't know if those patients were stopped because they got better or they were just declining, so it stopped. And I also don't exactly know what their definition of relapse is. But anyway, they plotted here on a Kaplan-Meier curve, and about 8 months is where the median time to relapse was for both patients and for each index organ as well, about 8 months. And you can even see that even just a couple months in that there may start to be some decline there. Adverse events, for what it's worth, there was 17 patients, about half of them had some kind of adverse event, but 7 of those only needed to be the treatment needed to be permanently discontinued. 2 of those were for infusion reactions, 4 were for anaphylaxis. 3 out of those 4 anaphylaxis, they stated that there was some interruptions in their therapy. One of them actually had a flare of lupus pernio and actually some nodular disease. 1 patient died, which was attributed to progressing fibrotic disease. And the most common side effect was pneumonia, which is sort of consistent with what we would expect. They state that there was 9 non-serious infections, which I assume are 3 minor and 6 pneumonias. So I'm assuming none of these were like clinically significant pneumonias with respiratory failure requiring hospitalization, but it doesn't clearly state that. So this is my non-biased discussion. This is just what the authors are kind of stating from their end. Obviously, we can talk about more things after, but they suggest that infliximab is potentially effective in refractory sarcoid. It can reduce the steroid dose. Adverse effects were common, but permanent discontinuation was not, and that relapse was frequent within 1 year. They acknowledge that they use objective measures when they could, but some of the things they looked at were not necessarily standardized or validated. And how we define success also, which I'd love for us to talk about later, is not very clear, but that they are feeling that clinically stability could be considered successful in terms of the lung function and even CNS. They're saying that it was most successful in CNS and skin, similar to kind of the other retrospective studies that we looked at in the beginning. And also that maybe upper airway involvement, because they had a big population, could be responsive. And then obviously there was only one of each of these groups, so they're making no claim for those. They're counting the steroid reduction as a critically important outcome, and that relapse, similar to other data about infliximab discontinuation, was relatively high, but they didn't really have a clear understanding of why they stopped it and if it was because they got better or worse. They really kind of comment on how this is an off-label medication that's really often not covered, and it really should be approved. And they quote say, waiting for prospective RCTs to approve therapies for sarcoidosis is unrealistic and potentially unethical. So be interested to see what people think about that. I think I can respect that comment. And then some other limitations, again, that they are stating themselves are that the sample size was small. Obviously, it's retrospective and there's no comparison group. I'll skip this slide. Basically was to emphasize that there's some selection bias, obviously, when we're looking at these retrospective patients. Here's the references, and I will stop there and pass it on to Dr. Frame. And I invite everyone to turn on their cameras and join in the discussion. I guess I should stop. 20 minutes in now.
Hi, everybody. Thank you, Babak. That was great. I picked a couple of topics that I thought would be worth talking about. Obviously, the more participation we have, the better. I'd be very happy to hear what people have to say. The 3 subjects that I wanted to go over, first of all, I wanted to talk a little bit about cardiac sarcoid, which was not overly common in this group of patients. I wanted to talk a little bit about the use of TNF inhibitors, the way rheumatologists use them, and potentially other subspecialties like gastroenterology. But I think that the big topic of discussion has to be, where does this article lead us, and what should our next steps be? There's, as Babak mentioned, there's not a lot of really robust data out there. We have a lot of retrospective studies, and how do we potentially move forward from there? So I noticed that there are only 3 patients in the 33 that had cardiac involvement. That's potentially consistent with the data out there on how common cardiac involvement is in sarcoid, although estimates of the number of patients with cardiac sarcoid range widely. And I think that has to do in part with how hard you look for it. So if you're talking about people who have clinically significant cardiac sarcoid manifested, for example, by arrhythmias or heart failure, you're going to get a much smaller number than if you look with echo, cardiac MRI, PET CT. Those numbers, especially in some Japanese studies, get up above 50%. I'm going to assume that these were patients who had clinically relevant cardiac involvement. It's a tiny number. They couldn't have done much with the information. But I think cardiac sarcoid is especially interesting and challenging because it's so hard to gauge disease activity and decide whether or not you've had a treatment response. So there are a number of different ways that people try to do this, starting with clinical outcomes, moving on to lab tests like troponins and BNPs, but particularly with these more advanced forms of imaging, it's really hard to follow up on these patients. one of the other things that I find really interesting about treating cardiac sarcoid in the setting of TNF inhibitors is that there is a black box warning on the TNF inhibitors saying that they shouldn't be used for patients with heart failure. I'm a rheumatologist, so these are medicines that I use all the time. Those warnings are based on a couple of trials early on in the history of TNF inhibitors, one with etanercept and one with infliximab for patients who had heart failure, in treating the heart failure, looking to see if TNF inhibition was beneficial for heart failure, and it didn't work. And also on some early post-marketing data, looking at increases in heart failure among patients who are on TNF inhibitors for other reasons. And yet, one of my favorite articles is an article by Dr. Baker and his colleagues at Stanford back in 2020 in Seminars in Arthritis and Rheumatism, which was a retrospective study, as are so many of our studies, with 77 patients with cardiac sarcoid. For cardiac sarcoid, that's a respectable number. Of those patients, 20 of them, which is about a quarter of them, were treated with a TNF inhibitor, a variety of different TNF inhibitors. And actually, so most of them were treated for progressive heart failure and for tachyarrhythmias. Actually, all of them had a meaningful benefit. So I think that this is something that definitely deserves further investigation. This study didn't turn out to have a lot of meaningful information about it, but I would say for sure, if we're thinking about future directions, looking specifically at TNF inhibition in patients with cardiac sarcoid is going to be useful and interesting. I want to pause there for a moment and see if anybody has any comments or suggestions with respect to the way they manage cardiac sarcoid or even how they follow it.
So I'm a rheumatologist. My name is Mike Pincus. I work over in Boston at the Leahy Clinic, and we're in a sarcoid group as well. And I use infliximab kind of first-line therapy with steroids for these cases right off the bat. And we have a cohort of maybe 30 patients right now, and we monitor them serially with PET CTs, have done remarkably well. Only one patient has failed. And even in patients with very low EFs, because those two studies, the etanercept and the infliximab studies that we talk about, they were high dose steroids. They were high doses, and they weren't the common doses that we use in rheumatology. So with close monitoring, we put these patients with low EFs on infliximab, and I had a guy go from a EF of 15 to 20 to like 50, just because we addressed the disease. But that, there is always that risk of, legal risk of doing that. It's a black box warning, and we do it. But I think it needs to be more accepted widely as we start treating these patients that more aggressively when they have CNS or cardiac symptoms. I think you can't really take your time with methotrexate failures and azathioprine failures to get to that point.
Yeah, I mean, I think that's reflective of our experience here. I'll often start with methotrexate if for cardiac disease, if I think there's room, if there's time. I do think that CNS disease, I would consider infliximab first line. And of course, there is also a black box warning for demyelinating disease with the TNF inhibitors, in case anyone's not familiar with them, but that's not what we're talking about in sarcoid. I would say that with the TNF inhibitors in cardiac sarcoid, they can be especially useful when you don't want to use methotrexate. I mean, a lot of these patients either have lung disease or liver disease that might make you anxious about putting someone with significant disease on methotrexate. And the TNF inhibitors, in my experience, tend to work faster. There's also the question, which I'll move around to in a minute, of whether you want to put someone on infliximab by itself, or if you commonly use it in conjunction with another disease-modifying agent like methotrexate. Anybody else have any comments on cardiac sarcoid, how they diagnose, follow, or manage it?
Hi, everybody. I'm Yogita Rushlani. I'm a heart failure cardiologist at Montefiore Medical Center in New York, and I direct the cardiac sarcoidosis program here, work with our pulmonary and rheumatology teams to take care of these patients. If you guys don't mind me asking a question, I'm just curious. I have a few patients on TNF-alpha inhibitors, and I usually mostly use it as a second or third line agent after steroids and methotrexate or steroids and mycophenolate. When do you stop these agents, or how do you consider weaning people off? Or I'm curious to get your thoughts on that.
the TNF agents specifically. So just to start, I mean, obviously there's not really data on this in sarcoid, but I would say that extrapolating from the diseases that I take care of, rheumatoid arthritis and so forth, I don't generally expect it to be something that I stop. So most of my patients are going to stay on it until either they fail therapy or something changes. If I were looking at a patient, let's say, who is on steroids, methotrexate, and a TNF inhibitor for whatever kind of bad disease they have, I feel like steroids have the most toxicity, and I'm going to try to get them off of that first. Methotrexate and infliximab, I think, often are a good combination. If I'm thinking, someone's doing really great, I might back off. Like I might go from 5 milligrams per kilogram every 4 weeks, slowly bit by bit down, and see how little I can get away with. But as you saw in so many of those studies with sarcoid, same is true for our diseases. If you stop it, the disease comes back. Anybody else have thoughts about that?
No, that's a good point. What I wonder about is, and that's what our rheumatologists tell me also, that we only have a few patients on TNF alpha inhibitors, but they are also reluctant to ever stop these infusions. But I was wondering if the disease is quiescent on PET scan and the EF has improved, or they're not having arrhythmias. Would you I mean, if you look at some of the cardiac sarcoidosis literature, even the prednisone, people say you give prednisone for a few months, then try to taper it down, see what happens. With TNF alpha, do you ever step back down to a second line agent and hope that the inflammation is now under control, and can you go back to methotrexate alone, versus should you continue both to prevent development of antibodies?
I mean, I guess the question is, why would you want to do that? So obviously every medicine has its side effects. In my opinion, the risks of the TNF inhibitors are, obviously there's a lot of infection to go with it, but there is with methotrexate and steroids as well. I don't think of these as drugs that I absolutely have to get someone off of. Yes, they're going to be an ongoing risk for infection, and they need to be screened regularly for things like exposure to tuberculosis. I make sure they're up to date on their vaccinations. They get more skin cancers, but for the most part, these are pretty well tolerated. Certainly, I think this is a good segue into how we use the TNF inhibitors, but for infliximab, because it's a chimeric antibody, there's more concern about formation of anti-drug antibodies. So I do tend to use infliximab with methotrexate to prevent those antibodies from forming. But something like adalimumab, where there's less risk of HACA formation, I would probably be more inclined to stop their methotrexate and continue their TNF inhibitor. The methotrexate obviously has risks associated with it, such as liver disease and bone marrow suppression, requires regular drug monitoring. So while I would be willing to back down on a TNF inhibitor if someone really had a good socked-in remission, it's not the first drug I would want to get rid of. And maybe that's a good moment to talk a little bit about the way we use the TNF inhibitors. Can you guys, and Dr. Cox is saying cost is a consideration for some. This is a big issue in general. I mean, first of all, yeah, these are much more expensive medicines. Like, no doubt, methotrexate for a year for a rheumatoid arthritis patient costs a few $1,000s. A TNF inhibitor can cost $20,000. So in terms of, the healthcare system, yeah, it is an issue. That's definitely true. In terms of the individual patient, it can be impossible to get these paid for sarcoid, because who's, approving this as an on-label kind of an indication. Let me move on a little bit to the way we use TNF inhibitors. Can you guys just do the little emoji, raise your hand, if you're either a rheumatologist or a gastroenterologist? Dr. Pincus is a rheumatologist. So looks like maybe there's a lot of pulmonologists on here and cardiologists. So I would say the TNF inhibitors are used primarily by rheumatologists and gastroenterologists, maybe some dermatologists. The rheumatologists and the gastroenterologists use them slightly differently. So certainly for, the first thing to know is that there are different varieties, there's a bunch of them and they're not all exactly the same. Etanercept is different because it's a soluble receptor. So for the most part, it's not binding to cells, and you're not going to have any cell lysis. It can bind to lymphotoxin, which is a little bit different than the others. Infliximab, as I said, is a chimeric antibody, which gives it issues of its own. Certolizumab is pegylated. And if you have a patient who's likely to get pregnant, that's nice because it'll prevent it from crossing the placenta. And they do tend to have slightly different efficacy. And certainly within a patient, somebody may fail one and then respond well to another. As a general rule, I would say that rheumatologists tend not to check antibody levels or drug levels. So on the whole, I use infliximab with methotrexate to prevent antibody formation. I'm less likely to do that with the other TNF inhibitors. I generally decide on the dose based on how the patient's responding, and I tend not to follow drug levels, and I tend not to check antibody levels. The gastroenterologists, in my experience, are much more likely to follow both of those things. I think that the data for that is not particularly robust. I don't think, as far as I've ever seen, that there's any literature that says following antibody levels or following drug levels is important in terms of outcome or will help you guide dosing. There's not a toxicity associated with levels. So for example, if you're using tacrolimus, yes, you should be checking your trough levels. But if you're using infliximab, there's not a therapeutic window really that you're looking for. And there's not a lot of data to give you a target range, even in the diseases that I take care of, for which it's approved. I'm not 100%, I guess you could say, I'm not sure if they're responding. I'm not sure if the problem is that they're losing response to it or just clearing it out quickly. Maybe in a situation like that, you might decide to use those kind of tests. But for the most part, I don't. Do you have a different approach, Dr. Pincus?
So often if I use infliximab alone, I will check trough levels if I'm not adding methotrexate and antibody trough levels together, because sometimes the symptoms are relatively vague, and I rely a lot on, unfortunately, serial PET CTs on these patients, maybe annually, and without obvious arrhythmia or heart failure symptoms. And if they don't have other, more easier to monitor features like PFTs, and then I wind up doing it maybe to rationalize putting them on metho with it. More recently, I would say, I've been adding like 7.5 of metho with the infliximab to cover antibody formation. But alcohol is always an issue in many of my cases, and I feel like I have to balance that with them as well. And a lot of them don't want to go on methotrexate.
That's true. And, certainly if you have a patient who's got sarcoid affecting their liver, theoretically, you give them medication and it gets better. But at the same time, for either the liver or the lung, if you put someone on methotrexate and their organ seems to get worse, and then you're stuck not knowing if it's a treatment failure or a drug toxicity, that's just complicated and problematic. So I think that, the way we use these things in sarcoid really it's close to a data-free zone. And that really brings me to my last and I think biggest question, which is, this was a great article in terms of a retrospective study, super useful, brought up a lot of important questions, but it's not what any of us would wish for if we got whatever we wanted. Obviously, I think everybody would be more interested in prospective and randomized double-blind clinical trials to see what worked. There's a lot of problems with that, though. I mean, we're not even close to starting that. I would say there's a bunch of questions that are worth talking about in terms of what would the ideal research setup be. And these are questions that come up all the time with an individual patient in a clinical setting as well. I mean, I think that, the first thing that probably most of us do when we see a new patient is go through and catalog the organs involved. And that, there are ways to do that. Everybody has their list. But then how do you assess disease activity and severity? And that's obviously going to be different from organ to organ. So disease severity in the skin, I think you have to take pictures. I'm not personally capable of saying, well, I'm thinking back to 6 weeks ago, and I'm really pretty sure that that skin rash looks like it's better. In terms of things like, the lungs are a lot easier than some of the organs because you can check PFTs and you can get, serial CTs. Liver, easy. You've got, blood tests you can use. Cardiac sarcoid, one of the reasons that I find it so intriguing is because it is so hard to follow. I mean, you certainly aren't going to follow clinical outcomes. Wait till somebody has a tachyarrhythmia, or wait until their ejection fraction drops to 15% as an outcome measure. So I think that the first discussion that you'd have to have before you could really run an optimal study would be exactly what are your disease outcome measures, and that's going to differ from organ to organ. So this paper had a very nice table set up with how they defined treatment success, or at least stability within an organ. If it would be great to have that sort of thing defined in a more commonly accepted and universal way, so that all the different studies were using similar disease outcome measures. The other question that's sort of like a corollary there is, if you're going to study sarcoid in a optimal way, do you split people out so that you have a trial of skin disease, a trial of CNS disease, a trial of lung disease, or are you going to try to come up with a composite score that's going to give you an overall impression of how everything does? So within rheumatology, we have validated disease activity measures. And for something like rheumatoid arthritis, that's going to take into account a tender joint count, a swollen joint count. Usually it'll include global assessments from the patient and the physician, and sometimes it'll include a sedimentation rate, for example. Relatively easy because you're mostly dealing with joints. Absolutely does not take into account the patient who's got interstitial lung disease or vasculitic ulcers or any other manifestation of rheumatoid arthritis. In some ways, I would say the better analogy is lupus, because lupus is such a multi-organ system disease, similar to sarcoid. There's a lot of different parts that can be affected. There's a, commonly accepted disease outcome measure, but it's complicated. It's 16 different clinical characteristics and 8 different lab characteristics. So this is something that is very useful in a research setting, but pretty cumbersome in your average office setting. That's a tough one to move all the way through in an office visit. And yet, that's the way clinical trials in lupus are done. It'll take into account all those different parts. So I'd like to sort of open it up for discussion if anybody has particular thoughts about this. And I would say, maybe particularly rare disease. Could you enroll enough patients to do one organ at a time? Is it better to try to come up with a composite outcome measure? What do people think?
Hi, I'm Barney Stern. I may be the only neurologist on this call, so forgive me. But I'm at Hopkins, and we've had discussions about this type of thing in terms of clinical trials. I think there are a couple of issues. First of all, I agree with many of the comments people have said up until now. I was one of the co-authors of the CNS infliximab study that was quoted earlier this evening. I think one way of trying to assess in a prospective manner is, first of all, within a multidisciplinary setting, try to decide which is your target organ system for which you want to treat with infliximab. Number two, for that organ system, what might be a symptomatic clinical feature that you want? Shortness of breath, cognitive functioning, etc. What is an imaging correlate? In my case, it would be brain or spine MRI. And what might be a physical diagnosis measure? Stand up and walk, a 6-minute walk, something, a time composite measure. modified Rankin scale, and other neurologic scale. And then as secondary hypotheses or aims, you could also do so that for each patient, you have a target organ system, plus then you have correlates for, do they also have pulmonary, do they also have heart, do they have skin, etc. And my guess is that you can get a lot of information if you did a prospective one-year study to really see how patients stabilize. When we looked into doing a prospective study, we were unsuccessful in getting any drug company involved in terms of sponsoring the drug. Now, maybe if we went through an organization like FSR and showed that it was a multi-D, large N type of study, someone might listen. But the reality is that the drug companies, and now with biosimilars, they're on the market. So for them to invest, so then you're left with going to NIH or another grant agency. And at least when we put out feelers to NIH, at least within the neurologic branch, it was considered too much of an orphan disease to get excited. Now, again, the pulmonary branch has been more interested in multidisciplinary efforts. And again, as a group, we might be able to get some traction talking to NIH in as a group effort. Finally, you have the issue of biosimilars. And although we're talking about infliximab, I know that our patients are starting to flip from Remicade to whatever, and it can change every 6 months. And that's going to be a confounder in terms of study design, because we really don't know if all the biosimilars are indeed biosimilar.
Especially in a disease like this where it's so little studied. In terms of other insights into research, like it seems to me like this is certainly a disease that you would expect to do better in a multi-center trial just because of the rarity of these things. Would anybody say that they would prefer a single organ trial, or does everybody think that best to do everything all at once?
Hi there, this is Sean Burial. I'm one of the pulmonologists at De Novo Fairfax Hospital. It's this has been a great journal club, and I'm very I'm very impressed with all the discussion that's happened. Just personal experience, it's kind of similar as what you've described. I think cost is an issue. First of all, as pulmonologists, just trying to establish refractory disease, going through steroids and second-line agents over to infliximab is often a challenge. Getting PET scans for lungs is a challenge, and eventually, getting infliximab for our patients is often a challenge. I think it makes sense in strength of numbers to come with something like Barney suggested in terms of a trial. But I can certainly understand how drug companies would not want to fund it at this stage. But maybe that's what we're here for, FSR, and kind of push the envelope in trying to get trials that are much needed.
Before we close up, I wanted to give Dr. Cox just a chance to, if he wanted to make any comments. He was one of the co-authors on the retrospective paper that we had. I know we're running short on time.
Thank you, and thank you for being so gentle with our inadequate methodology. We acknowledge. The reason why there were so few cardiac patients in that study is that we have a separate somewhat separate cardiac therapy group. And we're part of a Canadian-wide study called CHASM, CHASM, which has now just about started a treatment trial using prednisone and methotrexate. So they were separate. We've had a separation. Same doctors take care of the patients with sarcoid, cardiac, and others, but we've had great luck in cardiac sarcoid with the first and second line therapies. We've actually had very few people go on to anti-TNF drugs with cardiac sarcoid, but we do echo the experience that's been shared already that it does work quite quickly. And we've had so far no failure of anti-TNF therapy in our patients with cardiac sarcoid. And in fact, when our patients on anti-TNF therapy with cardiac sarcoid have had a clinical deterioration, those have all had a separate explanation found other than the deterioration of their sarcoidosis. So that's our little track record in that domain. Someone asked a question about, do you go for a single organ trial or do you go for multiple organs that have refractory sarcoid? I don't know how to answer that. I think that once you have multiple organs, you've got different scales, and that was a weakness in our trial. We have stability of one organ involvement is a success, whereas improvement of another was a success. That's really, really hard to deal with that. So if a purist, I would say, if it was a purist looking at it, I'd say they would look at single organ involvement would be your number one, would be a better model. And then to get a network of the treatment centers together to contribute. So that would be how I'd see that finishing out. I also feel that we have focused very much on infliximab. We heard that there are alternate anti-TNF drugs, but adalimumab has not had much of a success record in sarcoid, and we have really focused very much on infliximab as our anti-TNF drug. So we don't have experience with the same range of biosimilars that were mentioned earlier that I presume will come. We lag behind the States in availability of these drugs by some months or years. So we'll have more experience in the future. I was stunned that our study was actually picked to be discussed because it was very much the frustration of that somebody mentioned earlier, but how do you stop these medicines when you start them? Starting them was actually relatively straightforward. People have become quite comfortable. What we discovered was we had no rules for stopping. And it was to try and capture our experience to see whether we should and could be stopping them in a safe way. That was actually a major motivation to collect these patients in these two centres. And it was actually an opportunity because one of our colleagues had trained in England, in London, in those two centres that contributors, and then was back with us and said we should pool it together because we had fairly similar philosophies. And that's where it happened. And we've ended up with a 2/3 relapse rate within a year when we stop anti-TNF drugs. And that has certainly been a caution to us about trying to generate some sort of a protocol for pulling back and stopping anti-TNF drugs in difficult to treat sarcoid. We have failed to come up with a usable protocol for stopping these drugs. So that's all I'd have to say. Thank you very much indeed.
Thank you.
Thank you.
And thank you, Dr. Ockhaven and Dr. Frame and everyone who participated. We now welcome FSR Sarcoidosis Journal Club Leadership Committee member, Dr. Shambhu Arial, for closing comments. Dr. Arial serves as medical director for the Innova Lung Transplant Program and Innova Sarcoidosis Center. He is board certified in internal medicine, pulmonology, and critical care with expertise in lung transplantation, sarcoidosis, interstitial lung diseases, pulmonary hypertension, and bronchiectasis. Thank you, Dr. Shambhu Arial.
Thank you, Diane. Oops. Can you hear me? All right. Well, thank you very much for that very kind introduction. And thank you, everyone, for attending this excellent journal club. Very well done. And I congratulate the co-hosts for doing such a great job. After attending this session, we hope you have had a new appreciation for critical research in an orphan disease like sarcoidosis. I mean, this is preaching to the choir, but you know, I think it never hurts to say it again. As far as the FSR Global Sarcoidosis Clinic Alliance, you know, it's an organization consisting of clinics, hospitals, and individual providers committed to finding a cure and offering evidence-based patient-centric care for those living with sarcoidosis. And we're proud to be a partner. This is just one of many clinician education programs that FSR Global Sarcoidosis Clinic Alliance will deliver in 2023. As a reminder of our Sarcoid Journal Club series, you know, we'll have many more in the months to come. I think we might have a slide here to just to remind that. So I'm really looking forward to, as you all are, to these journal clubs. And I think there'll be a short survey at the end, and please remember to answer the survey so we can make it better. Thank you very much.
Thank you, Dr. Ariel, and thank you again to everyone. You are the people that make these programs so terrific. So we really appreciate your attendance and participation. And you can look for all the links that we put into the chat in the follow-up email, as well as the recording. Good night, and thank you again.
Thank you.
Thank you.